like 2 months now, and she is on with us every week, all the time, helping get this information out there. And Dr. Subramanian, we're just so grateful to have you. So I am going to pass it over to you, Dr. Subramanian, to introduce our guest and kick us off.
Thank you. So it's with great pleasure that I introduce my dear friend. He's an old friend, and we're still very close. Dr. Tagliati, Michele, as I fondly call him, and my kids have different nicknames for him as well. We have kids about the same age, and it's just been a pleasure to develop a friendship and a working.
To talk about Dr. Subramanian, I had the privilege of knowing her now for almost 20 years. She was in kindergarten at the time, and she is an amazing mom, an amazing doctor. I don't know how she does it, but one of the reasons why I actually moved to Los Angeles have to do to the fact of having Indu support in LA. I was coming from New York, and I didn't know anybody in LA but Indu. Of course, Cedars-Sinai made me an offer I couldn't refuse, but other than that, this Indu here was a key reason for me to move to Los Angeles. So thank you for having me in Los Angeles, Indu, and thank you for having me here today. Why did I go to neurology? Oh, this is a, can I go a little personal? I mean, it's
what we're here for.
So in Italy, you might know, we don't do college, right? We go straight from high school to medical school. And at the time, I had a girlfriend who had a neurological problem, and we don't need to get into details, but as a young man, I was really impressed by the suffering and the disability at age 18, 19. And so that really pushed me to decide what I wanted to do with my life. And I decided that I wanted to help people as a doctor, and in particular as a doctor for neurology. She didn't have Parkinson's disease. She didn't have any movement disorder. That came a little bit later when I was in medical school. I remember I met this very nice neurosurgeon that was somewhat involved in the treatment of Parkinson's disease at the time, and he counseled me. He told me, why don't you start following the Parkinson clinic? And so a very, very young stage of my career, when I was still a medical student, I started to do research in Parkinson and the dopamine system, and then the rest is history.
It's history. Well, we've been lucky, and the patients have been lucky to have you. And so over the years, you've developed all kinds of different interests. I think you really have made a name for yourself in the surgical fields, and really pioneered some work in dystonia, which we won't get too into. But, I had a working relationship with you even when you were in New York, sending complicated dystonic patients all the way to New York to get a consultation to see if they would be appropriate. So I've relied on your advice and your guidance and your expertise for a very long time. And you've taken great care of so many of these patients, some of whom still fly out here from New York to get care at this Sinai. So really, hats off to you for that. But I think what we can get into today, because I think it'll be relevant to our Parkinson's patients, which is more the topic of this. I wanted to spend some time talking about some of the research work that you've been doing. And maybe we'll start with the really interesting work from the Nature paper that you published with some of the stem cells. And maybe you can start with that, because I think that's really, really interesting and exciting.
Absolutely. Thank you for the question. I'm going to say with something that's going to make people smile, but we published at the end of January. I feel like it was 5 years ago, but it's been such a long 3 months. But at the end of January, we published this very, very interesting paper in a very prestigious journal that is called Nature, Nature Medicine. And it was a study on patients with young onset Parkinson's disease, so patients that develop Parkinson at the unusually early age. All of them develop it at age 40 or earlier. And the reason why we wanted to look at this specific population was that we believed that they might have some intrinsic, they didn't have any genetic or at least non-genetic problem, but if someone developed Parkinson's so early, we might find something that is intrinsic on the way the dopamine cells work that we might discover even using stem cells. And this is probably the first take-home message. We were using stem cells not to treat Parkinson's disease, but to study Parkinson's disease. And as some of you might know, we can now derive stem cells from pretty much any individual. Anybody can have their own stem cells. I mean, I'm not saying that, you know, everybody can go there and get their stem cells, but in theory, at least, it's extremely expensive and time consuming, but in theory, everybody can donate a sample of blood, and from that blood, we can, with reverse engineering, basically derive their own stem cells. So we were able to derive specific Parkinson's stem cells from patients that we knew had Parkinson's disease. So it was not like a general stem cell, you know, there are stem cells that can come from all sort of sources. These were stem cells that were coming from people that we knew had Parkinson's disease. So that was the first interesting part of the story. And with these stem cells, we ended up at the end of the study having 10 patients with the early onset Parkinson's disease. We had their stem cells. We cultivated them and induced them to become dopamine cells. So we induced these stem cells. As you know, stem cell can become everything, right? It can become bone cells, skin cells, an eye cell, a blood cell. We convinced these stem cells to become dopamine cells because we wanted to see if these patients that develop Parkinson at this early age had something that we could learn from on their dopamine cell. And sure enough, once we produced these dopamine cells and we started stressing them, so to speak, and tried to see whether there was anything wrong, they turn out to be unusually unable to handle proteins, and in particular, not surprisingly, α-synuclein, which I'm sure you know is the protein that abnormally accumulates in the brain of patients with Parkinson's disease. So basically, the amazing discovery was that even at the stage of development, earlier than birth, because stem cells and the dopamine cells that we had were like only a few weeks into development, so way before even being born, they already had abnormalities that then would probably explain why these proteins would accumulate and proteins would cause eventually the symptoms of Parkinson's disease. So a disease that is normally associated with aging, 60, 70 years of age, we found elements of it in cells that were not even born. And so that's really what made like a sort of a little bit of a media splash. You know, we found the element of Parkinson's disease before birth. Now, we all know to some degree that Parkinson's disease is considered a dual hit, right? You need a predisposition, whether it's a genetic defect or some predisposition, and then something else, some environmental hit, you know, whether pesticides or whatever type of stress, head trauma or other problems during life. So it's not a complete unexpected idea, but one thing is to theorize that there must be some genetic problem. One thing is to show it before even the cells are ready to be part of a finite organism. But the third and most important, in my opinion, part of the story is that this defect in handling these proteins was reversible. In other words, we found a bunch of chemicals that were able to fix the problem, to allow the cells to dispose this excessive accumulation of alpha-synuclein and pretty much fix the problem. And the interesting part of the story was that the fixing was not specifically a fixing of the specific abnormality, but it was almost like opening another window through which the cells was able to eliminate those proteins. So it was a general fix. It was a fix that in theory, we might apply to other types of Parkinson's disease, not just to the early onset, pretty rare type of Parkinson's disease. So that's why it was published in such a big, important journal, because we really opened a lot of wonderful avenues of research. I have to give you a word of caution, however. These chemicals are very easy to use in the petri dish, in the stem cells, but they're not that easy to give to human beings. They're actually a little toxic, and they've been used in some cream for skin cancer, but they've been recently withdrawn by the FDA. So we're trying to find steps to put all this knowledge into practice, into real therapies. But don't go out there and put PEP 005 on your skin, because we are not ready to go to prime time with this treatment. So I hope that this was clear. Of course, I'm very enthusiastic about this research, but again, stem cells used to study Parkinson, not only to treat Parkinson, a new unexpected defect of these cells. And number three, a treatable defect. Now we have to figure out how to actually treat it in real people.
Okay. Yeah, it's quite complicated, isn't it? So, so there's a question that came through just about, so when we do use stem cells for treatment, maybe as a, as a parallel or the opposite sort of scenario to this. So we're in this situation, you're looking at stem cells, which my understanding is these are cells that are in, in fetuses that are developing, that can go in any which way. So this is a cell that has not been differentiated. So a cell that is just a cell that, given the right programming, can become any part of the body. So sometimes stem cells end up as bones, like you said. Sometimes they can end up as neurons, like nerve cells that are all over the place. And then some of them go on to become the cells that produce dopamine. So you took a stem cell, you were able to take blood from a patient, reverse engineer this. So you basically turn back time to these stem cells, which is a process. Then you took these stem cells, which then could grow into anything. You program them in some magical way to become the cells that would produce dopamine in the brain. And then when you showed that, you were able to do the dopamine cells from this specific patient that developed Parkinson's in real life very early on. Those cells, when you stressed them, you made them unhappy and made them produce protein. Those proteins accumulated very quickly. And
Correct.
So normally the cells in a normal cell that's happy, those proteins would be cleared or not accumulate so quickly. In these cells, there was something that was wrong with these stem cells that is likely what really caused this younger person to develop younger Parkinson's, right? So
Right.
then you
were already dopamine cells. They were not stem cells anymore. They were already dopamine cells. Very young, but already dopamine cells, yes.
They were already destined to become dopamine cells, and those cells were already dysfunctional to the point where they were accumulating these proteins in a weird way. So I think this is a different thought of using stem cells to see what is the eventual evolution of that cell. But then I think there's been some questions about, I think what people get tripped up about is they hear all about stem cells being used all over in Mexico and China and using these stem cells for treating Parkinson's. Michele, can you explain when they're using treatment from these stem cells, what are they talking about? So it's not in this experiment, but in a theoretical way for using stem cells to treat.
So disclosures, I'm very, very, very careful about even talking about stem cells for treatment, because even though there is a tremendous amount of research, much of what you read in terms of treatment is a little bit of hokey pokey out there, because even though it elicits a lot of hope, it does not really deliver on that hope, and it's not supposed to deliver on that hope, because it basically assumes that you inject some stem cells into your vein, those stem cells magically go to the brain, go to the right place, develop into the right type of cells, and then do magic. And that unfortunately does not happen. It just does not happen. Now, there are different stories. Is that there are some trials in Japan currently. There is something that was published like yesterday in New England Journal of Medicine of much more controlled studies in which, because again, the stem cells, they need to become dopamine cells, and that's the tricky part. I mean, if you just inject the stem cells, you may get a bunch of bone cells in your brain. I'm making it silly in order to make it clear, but and so the challenging problems are twofold. One is to convince the stem cells to become the cells that you want them to become, dopamine cells or whatever. And number two, make sure that they make the right connection in the brain and therefore end up functioning the same way the old dead Parkinson dopamine cells cannot function anymore. And my view of all this line of research, which is extremely exciting, is my caution comes from the fact that we have been there already. We have done fetal cell transplant. We have done genetic research. And what we found, unfortunately, is that we can transplant cells pretty safely and pretty effectively, and then they kind of become sick again. They become Parkinsonian again. The original fetal cells trials of Dr. Olano back in the late 90s, they found that these cells were becoming Parkinsonian, almost as if there is something going on that no matter how many fresh new cells you put in there, you may just expose them to whatever disease is going on. So that's where my caution comes in. But definitely there is a great research, and I encourage everybody to follow this research. But if you ask me, if my patient asks me, oh, should I go to Germany or to China or to wherever, there are in Santa Monica for that matter, to get some mesenchymal stem cell injected in my vein, my answer is no. They're extremely expensive, and I cannot endorse this type of treatment, unfortunately. Trust me, if they work, that would be the first to inject them myself.
And you actually have a really interesting background in the fetal cell world, because you actually did surgery on some of these patients that got fetal cell transplants that ended up with dyskinesia, right? Back in New York. So.
Yes, we had those patients that had fetal cell transplant, and they end up working even too well. And so they end up dumping a lot of dopamine in the basal ganglia. And so these people develop intractable dyskinesia. We ended up having to do deep brain stimulation to stop the dyskinesias in these people. So that's why I say that we have already been down that line in terms of transplantation. And we know that we can do it. Our surgeons are amazing, and they can safely, implant whatever type of cells in the right place. But then how to control these cells, how to make sure that they do what we want them to do. And again, because we don't have a specific perfect idea of what Parkinson's disease is to start with, we might expose these new cells to the same toxic, and I use toxic in general terms. I'm not saying that there's a specific toxin there, toxic environment, and they end up become diseased just like the one that were there originally. So there is a lot to learn, a lot to study before we're ready. And I'm sorry to trust me, people that know me, I'm the most optimistic and positive guy. But in this case, I really hesitate to pump the stem cell story too much, because I don't want to create false expectations.
Yeah, I agree. I think there's a lot of false hope out there. A lot of people who are trying to often, take money from patients. And, if you're out there, if somebody's trying to sell you something that's purported to be a cure, that's going to cost a lot of money, that isn't available through the normal channels that your neurologist is speaking about, especially if it involves, injecting cells or things like that, this could be quite dangerous, and definitely talk to your neurologist about this. And I think Michele and I are very open to having these conversations. So that's very helpful. So you talked about, this sort of early finding of an abnormal chemical that may influence the protein in these cells. And then, when we take that sort of study and then try to take it towards something where eventually we have applications in patients, I wanted to bring up another study that you're doing, and then maybe we can help patients understand a little bit about the phases of studies and how sort of the process happens, because I think you've been involved in studies very early on in phase 1, and then, or even pre-phase 1, and then have followed patients through and are currently conducting very exciting trials, in stages 2 and 3, phases 2 and 3. So maybe you could help us understand and also tell us about this exciting work that you're doing with some of the glucose modulating diabetes sort of family of medications that you're studying as well.
Yes. Thank you for asking. So let's start from the stages of research very, very briefly. But there are different phases, and usually the stage 1 is when we are just making sure that the compound is safe. Sometimes the phase 1 is not even done on patients, or it's done on volunteers to kind of study how long the medication lasts in the body, whether it is tolerated in general by the human organism. And then in phase 2, we start testing the medication in small groups of well-selected patients with that specific disease or that specific problem. And again, we are mostly concerned about safety, but we start to take a look also at whether we can see some maybe biomarker of improvement in these patients. After stage 2, if those results show that the medication is safe, and then maybe there is some element of improvement, then phase 3 is usually what we normally call a clinical trial with many patients, depending on the type of disease. It may be thousands for diabetes or stroke, it may be hundreds for Parkinson. That's a little bit less frequent. And then you basically look for statistical evidence, statistical numbers that show that if you take the medication, whatever that is, as compared to a control, which is usually placebo, which of course introduce elements of uncertainty, and many people don't like to take placebo, but this is a different story, which tell us that the improvement that we might have observed in phase 2 is not due to some excitement, to some faith that this will help, and instead is due literally to the pharmacological, to the chemical interaction of the new medication. And then phase 4 is what we call post-marketing. Is extra research that you can do after the medication has already been approved. And what we're doing these days is to explore a line of research that has started a few years ago in Europe, and is trying to exploit an old correlation that was noticed back in the 1960s, 1970s, showing that Parkinson's disease seems to have some correlation with diabetes. Why diabetes? Well, initially it was just a curiosity, like people with diabetes seems to have more Parkinson's disease than people without diabetes. But then with time, we found out that there is an element of diabetes, which is insulin resistant. Insulin, as you might know, is the hormone that is the body uses to metabolize and to use sugar. And if for whatever reason insulin become low in the body, the sugar starts rising in the blood, and we get diabetes. To put it very, very simply. So we found, somewhat surprising, but with other groups, that the patient with Parkinson's disease seems to have unusually high instances of insulin resistance, and usually is unknown. They don't have diabetes necessarily, but their body seems to struggle a little bit in keeping that glucose under normal levels. And this is well known with aging, and not surprisingly, Parkinson is a disease of aging. But it has spurred ideas that maybe treating that insulin resistance, which can be addressed with medication for diabetes, might actually help the brain slow down the pathological process, the disease process typical of Parkinson's disease. So this idea of giving diabetes medication to Parkinson patients is not new. We didn't come up with that. But there is one specific type of medication, it's called GLP-1 agonists, and they basically stimulate the production of insulin. And it's been tested initially in London by my friend Tom Foltini. They published on a medication called exenatide, or exending, that is available to patients with diabetes all over the world. And they found that patients with Parkinson that were treated with this exenatide seemed to do better than those that were not treated with exenatide, suggesting that treating patients with Parkinson with a medication with diabetes, in addition to the medication for Parkinson, okay? This is not an alternative to levodopa or to whatever we are taking, might contribute extra help to the brain in slowing down the progression of the disease. Where are we standing? So we took that information and we are using a different medication that's called Liraglutide. It's out there, its name is Victoza. And it's basically a more powerful GLP-1 agonist. And so if that idea is true, this medication should be even more effective because it's a more powerful type of GLP-1 agonist. So we have just completed recruitment of the study with 63 patients with a 2-to-1 active to placebo control study. And we are blinded, so we don't know who took the medication, who didn't, similar to our patients. But we are very, very intrigued by the fact that more than a handful of the patients that went through the study came out better than they were before. Mind you, there might have been a very powerful placebo effect, but they were so excited and so impressed that they end up going to their doctor and ask them to continue the diabetes medication. So again, this is very anecdotal. I don't want you to go out there and take diabetes medication by any means. And I want to repeat it. I don't want you to go out there and take diabetes medications, especially not under supervision. But it's what I'd like to call an alternative path to the treatment of Parkinson's disease beyond dopamine, beyond levodopa, which is extremely helpful, but has somewhat reached certain limits. Like, we are very good at giving levodopa. It's extremely helpful, extremely powerful, but it has some limits. We need to find alternative strategies to help the brain slow down Parkinson's disease. And I believe that this is one of those.
That's really exciting. Yeah, I mean, I think the other exciting thing about using medications that are already available to treat other disorders is that they don't have to go through nearly as much rigorous safety testing and things like that. We already have, you know, post-marketing research and some of these other disorders. So it is exciting. It's kind of low-hanging fruit for some of us in research, but I think at the same time, I think we have to take everything with a grain of salt at first and go through all the phases of study, because as we've already shown, there's been a lot of diseases where we've had exciting phase 1, phase 2 studies, even early phase 3. And then when we finally get to the end of our phases, we see that there's, you know, some placebo effects and things like that. Now, you had some very interesting research and analysis historically on the placebo and nocebo effect. Maybe we can just talk a little bit about that, because I think you have a very unique history of having done a lot of surgical studies along the way. And so maybe you could tell us a little bit about your experience with these effects and how you think you know, these effects affect our ability to understand Parkinson's disease in these earlier phases.
Yes, I mean, the concept of placebo in Parkinson is very particular and very unusual, because the old concept of placebo is somewhat explained with dopamine. So the expectation, right? Which is a natural event. Whenever we expect something to happen and we are sort of predisposed to a reward, when that actually happens and we feel the pleasure of the reward, whatever that is mediated in our brain with the synthesis of dopamine. So in other words, creating an expectations in a patient that has low dopamine basically helps him or her to produce more dopamine. So the placebo effect is very typical. Virtually every single study with patients with Parkinson's disease has a huge placebo effect, because you kind of tamper with the problem itself. You kind of help people. In fact, I always like to joke, if I could patent placebo effect, I would be a gazillionaire, right? I mean, I would never do it, by the way, because it would be really unfair ethically. But placebo effect is a real effect, and is mediated by dopamine. So, and what you were mentioning before, that is particularly relevant with a procedure like surgery, because of course surgery has a huge expectation, right? It's a huge emotional investment, right? If I have to do brain surgery, boy, better believe that it's gonna work, because I take this risk of maybe having a stroke, maybe having something terrible happening to me. And so I have to strongly believe that will work. And I go to Dr. T or to Dr. Puratian at UCLA, and they seem to be very good, very professional. They've done hundreds of these cases. They're telling me that that's what I need to do. And so in my mind, I invest emotionally that is what I need to do, which is true, by the way. We're not selling smoke to anybody, but it is a huge psychological investment. And that helps you producing dopamine when the event occurs. So once you get the surgery, you basically feel better no matter what. And in fact, sometimes before we even turn the electricity on, people feel fantastic. There's they call it micro lesion effect, but in reality it's probably a huge big placebo effect. People feel fantastic right after the surgery, and in some cases, not the majority of cases, but in some cases that's the best time that they have. So there have been studies, you mentioned the nocebo effect, in which some researchers have questioned the real impact of certain therapies, specifically the surgical therapies, because it's very difficult to compare surgical to placebo, right? I mean, you either get the surgery or you don't get the surgery. I mean, it's difficult to pretend that you had surgery. There are ways to kind of do little surgery without penetrating the brain, but I mean, it's tough. And some studies basically tell people, look, you're gonna have surgery, but then, you're not gonna have surgery because we need to compare you to those who have surgery, but then we'll do surgery 6 months down the line. When we finish the study, we'll do surgery. So these people basically have a nocebo, like they know ahead of time that they will not have the surgery. So they don't build the expectation, they don't build the dopamine, and guess what? They do much worse than those who have surgery because of the surgery, because they didn't have the placebo. That's what nocebo means. So there are a lot of wonderful, just behavioral effect of what we do, of what we experiment that make it very worth it to be in this world. I mean, but they make it sometimes complicated to really figure out what is going on, which at the end of the day is not about publishing papers or being in the pocket of pharmas. It's really about counseling our patients to what really works and what doesn't, because there are plenty of what we call anecdotal experiences, people that do great, people that don't do great. But what we're trying to do is to have group experiences that tell us, on average, 80% of people, 70% of people, 20% of people, what is your chance to improve? That's what we're trying to do. There's never a guarantee, unfortunately. I wish there was. But so placebo, nocebo, these are all phenomena that are very relevant to Parkinson, and we need to be very aware of them when we counsel our patients. I hope I answer your question.
Yeah, absolutely. And the placebo effects are high, right? I mean, I think when we take a group of patients and we do surgery on, let's say, 10 of them, and then the other 10, and we've actually been at UCLA in trials where we would take the patient, put them under anesthesia, do a burr hole. The patient thinks they've had the surgery. The neurologist who's referring the patient thinks they've had the surgery. We've even blinded the radiology outcomes and stuff so that a different radiologist is looking at the scan. Only the surgeon knows. The surgeon's not meeting the patient. It's like the number of layers of blinding are very high. And, you know, if you look at just people who are in that placebo group who think that they did get something, those effects are sometimes what, 20% in some of these trials?
Up to 20% improvement, which is more than many medications. It's amazing.
It makes it very hard. And so when we're trying to interpret these studies, when we're looking at what the effect of the surgery is, what we do is take the effect of the surgical group and we subtract the effect of the placebo effect. And then that's the effect that we attribute to the actual surgery. So it's very interesting and very complicated and makes these studies so complex and really, you know, when we are trying to tell patients about what really works in a scientific and informed way, we do need to wait for each of these steps and stages to go through. From, you know, we've talked about, you know, patients that come in and talk about a chemical. So you were just talking about some of the chemicals that modulate at a cellular level with the stem cell trial or the study that you did. Yeah. That chemical, if we were to take that chemical and try to study it through these phases, how long do you think it would take, you know, for that type of thing to end up maybe coming to market?
So that's a great question. It's difficult to answer, but I can give you some personal experience. So for example, our current effort with the anti-diabetes medication has been going on for 3 years. And we may argue that because it's a single center study, it took us a little bit longer than it would if we use, for example, a collaboration with UCLA and USC, just to name good centers in Los Angeles. But in the best case scenario, it takes at least 1 year to recruit people, 1 year to follow them, because it doesn't make sense to follow them less than 6 months to 1 year. So there you have already 2 years just to collect the data of a phase 2/3. And then after that, you need a few months to analyze the data, publish them. And so here you have 2 or 3 years just to get the preliminary data that then would lead to a larger study, because the larger study needs large investments, and people unfortunately do not like to invest a lot of money unless they have some preliminary solid data that would, you know, justify certain investment in this treatment instead of another treatment. And then you go, there is another year to, let's do the calculation together. So 3 years in the best case scenario, because Dr. Subramanian and I did a wonderful collaboration. And then 1 year to organize the next study, another 3 years for the next study. We're already up to what, 7 years? 7 years just to test it. And then we have to go to the FDA and say, hey, we have a lot of results. And that's where repurposing will help, because if a drug is already on the market, the approval will be earlier. But we're talking about 7 year minimum. I would say 10 to be safe. 10 years, 10 years from the idea to the actual fruition. I like to call it prime time, right? When you can actually give the drug in the clinic. It is a long time, but it's necessary. The discussion is raging now, right? With the COVID, the vaccination, and the hydroxychloroquine, the nonsense that we hear right and left. But the reality is that in order to give people chemicals safely, we need to be sure that they, first of all, they do what they're supposed to do. And number two, even more importantly, they don't cause any unnecessary side effects or suffering. And so it takes a lot of time. It's frustrating, trust me. I would love to cut down that time, but it takes 10 years to bring a drug, in the best case scenario, to bring a drug to clinical fruition.
That's really helpful. And thank you for your patience and energy and fortitude, because it takes a lot. I personally don't have that sort of, I like to do this sort of thing a little bit more than that sort of thing. So, all right, I'm going to take some questions from the audience because there's quite a lot actually, and some of them are quite interesting. We may not get to, I know we had talked about some other topics, but we might have to have you come back, Dr. Tagliati, to discuss some of those. So one question.
I can come back.
Okay. So one question somebody asked is, does that mean, so when, after you talked about the cells that were, you know, predisposing to these abnormalities, so I think these are some of the early questions from that, talking about, does that mean I could test my kids to see if they are at risk to get Parkinson's disease from that stem cell study that you did?
So the answer is yes. The answer is, and I want to take it a step back and make it a little bit larger. So this effort is what I would like to define as the first step to what we call personalized medicine, to a time in which, with caution, because it impinges on all sort of privacy problem, we can literally go and figure out person by person what is their specific risk to develop this or that disease. And you can imagine what kind of can of worm this kind of approach can open up in terms of privacy, but also what kind of incredible perspective it can open in terms of precision and effectiveness of the disease. If you think about it, we call Parkinson's disease a syndrome, which, as we like to say, is as different as the number of patients that we know. You know one patient with Parkinson's disease, and you've learned about one patient with Parkinson's disease. So, but at the same time, we give everybody the same drug and the same dose, and we expect everybody to improve the same way, which is kind of ludicrous if you think about it. So the future of medicine is personalized medicine. It's literally being able to define specifically for each individual what is going on with them and what kind of chemical or non-chemical treatment might improve them. So in this case, this analysis of their stem cells and the ability to test in vitro, meaning in the lab, how their cells respond to medication A or medication B, can be a tremendous advantage, because we don't give everybody the same drug. We give the drug that responds, that their own cells, we know their own cells respond to specifically. So it's not just about testing your children, but about testing you, about what works best for you. And it may be different patient with Parkinson A to patient with Parkinson B, C, D, and so forth. I hope I answered the question.
Yeah, I think that's helpful. And even, I mean, we see patients that have known genetic abnormalities in the same family, and each of them can have very different symptoms and respond very differently to treatment. So I don't think that it's a universal thing where we find a gene and it summates everything. There's definitely a complexity, like you said, of these different hits. So maybe genetic predisposition with an environmental thing, and even, you know, genetics within the same person and the same family. So I think it is very complex. I'm going to try to now move to some of the diabetes questions that we have here. So one is asking about what improvements are seen in the PD patients receiving GLP-1 agonists.
Great question. Again, a big disclosure, big word of caution. We are double blinded. So we don't know exactly, at least in our direct experience, whether the improvement that we see are due to the medication or maybe to a massive placebo effect. But there are already studies that have been published. And what they've noticed is twofold. They found both an improvement, a statistically significant improvement of their motor function, their UPDRS, their Parkinson scores, but also an improvement of their cognitive function. So that's particularly exciting. A different study has shown slightly different nuances, different shades of improvement, but especially the last study published in Lancet by the Foltini group a couple of years ago showed a clear-cut improvement of their Parkinson's disease. Now, what we are looking for, unfortunately only time will help, is not only an immediate improvement, which we observe in some of our patients, but also a long-term improvement, a modification of their progression of the disease. And so we see in some of these patients, they lose weight, they have a better sort of health. And that's really probably if it pans out, is the most exciting part of the story, is whether we can change the trajectory of the disease and making it less progressive or less overall affecting our body.
Another question is, does treating with the diabetes medicine for PD cause the patient's blood sugar to go down? And maybe while we're on that, just maybe we can talk about some safety worries in general about this class of drug. Very
good question. Whoever asking, I can give them some credit. The FDA asked me to check that. So it's a very, very big, of course, concern. And the answer is no, surprisingly. We didn't have any case, any situation in which any of the 63 participants to our study had to withdraw because the blood sugar would go too low. The sugar did go low, but not to a degree that would cause any hypoglycemia. And I think that the secret there is due to the fact that these hormones stimulate the insulin when you eat. They don't stimulate the insulin at rest. So it's not that your sugar plummets down, but every time you eat, you get a better response of the insulin. So we found low glucose. The other safety concern for what we're studying specifically, which is liraglutide, was pancreatic enzymes. There was a concern that we might cause some pancreatic inflammation. And again, the answer is nobody had to withdraw due to that. We got a 2 or 3 high levels, but then they kind of revert by themselves. And what else? And there is, and these people lose weight, but nobody lost weight to a degree that we had to stop because they were losing too much weight. So there are issues that need attention, but so far, fortunately, the trade-off seems to be in the black. I mean, we have more potential positive than potential negatives.
Okay, that sounds good. There's a question here about what you think the placebo effect is from. Hope, faith, optimism, what's your sense? And if you can't fully answer that, Michele, we have a speaker coming up on who's really a big researcher in the wellness universe and very interested historically on this topic. So he'll be coming in the next month, so he can also explain this. But maybe if we could get your opinion.
Sure, I'm sure that your guest will be much more articulated than me because he's studying this aspect. But it's all of the above, and I just want to make a distinction, which is a fake distinction in a way. But so hope, optimism, faith are psychological attribute of the human being, right? And they're all wonderful things. I mean, you kidding? I have a faith in our work. I believe that the people like Indu will change our world. I have an incredible optimism. My favorite line, as those who know me, is that I'm not in the business of giving up. So, but that's the way we express with language and with behavior these sentiments. Then there is the chemical correlate, right? So what happens when I'm an optimist? What happens when I have an expectations? And that's where the explanation of the dopamine come into play. But the two are not mutually exclusive. It's not that because I believe that the placebo is due to the dopamine means that it's not due to the fate. You see what I'm trying to say? There are two different definitions of the same phenomenon. And of course, I don't expect everybody to go and study dopamine. I think that practicing positive thinking and any form of that, you know, from meditation to praying to yoga. I know that you're a wonderful yoga teacher, in addition to a great mom and a neurologist and a great friend. This woman, guys, they don't come frequently. Anyway, now that I embarrassed you, I strongly believe in that, and the placebo, more specifically to answer the question, is, I think, it has to do with the creation of an expectation, and the creating an expectations, I think, produce chemical changes that turn into stimulating the synthesis of neurotransmitters like dopamine, which happens in everybody, not just in patients with Parkinson's disease, but in Parkinson's disease, because of the specific problem, contributes to an immediate improvement of certain symptoms. So you and I, we don't have Parkinson's disease. We get excited, we get happy, we get this brain well-being because of our dopamine, but we don't have symptoms of Parkinson's, so we don't see a specific physical change, right? We may feel a inner change, a internal sensation of well-being. If you happen to have Parkinson's disease, in addition to that, you also have a visible improvement of your mobility, of your ability to walk, or you have less tremor, you have less whatever symptoms you're suffering, which becomes even more visible because, like, wait a second. One thing is to be happy. One thing is to have my physical symptom improving. What is going on? So that's the way I look at that. I don't see that the physical and the spiritual part as mutually exclusive, but as two different explanations of the same phenomenon, which is a real phenomenon.
Absolutely. Okay, so last few minutes, I'm going to ask you quickish things. So what, if you had to pick two mechanisms or pipeline medications that are in the pipeline, other than, of course, the diabetes drug that you're studying, what would they be that are possibly game changers in the next 5 years for Parkinson's patients?
Ooh.
5 or 10 years.
So I am I'm looking at alternative. So there are two big lines of research. One is the attempt of blocking the alpha-synuclein progression in the brain, which is a theory that is somewhat controversial but widely accepted. This progression of this abnormal protein through the brain, and so there are very interesting efforts to block this abnormal alpha-synuclein with all sort of antibodies, very similar to what we're trying to do with COVID, right? We're trying to block alpha-synuclein. And that's one thing that, if that theory is correct, will definitely tell us something on how to slow down or even prevent Parkinson. We are here, I'm looking with a lot of curiosity to alternative neurotransmitters, and particularly noradrenaline, and as you know, this is the stress hormones, and we are looking at possible studies to reduce the stress effect as a possible cause of Parkinson or cause of the progression of Parkinson. And I don't know whether that will be the solution or not, but definitely I believe that we need to go well beyond dopamine to truly understand and treat Parkinson's disease. I will leave you with this opinion that I feel very strongly. Okay.
Now, one other quick question. If you had one thing that patients should be advocating for right now around this disease, in any arena you pick, what would it be?
More funding for research.
Okay. That seems reasonable and a good answer. Good answer. That was a relatively quick answer, but okay. And then very broad answer, but okay. Last few minutes, Michele. This was lovely, amazing. You know, your research is amazing and always fun just to see you and catch up. Give us a few words of hope through COVID, maybe a silver lining maybe that you see from this whole situation with COVID, and then also just, you know, inspiration around the Parkinson's scene in general.
So yes, I've been very active in reviewing and teaching about the interaction of COVID and Parkinson's disease. And immediately the good news is that this seemed to emerge that Parkinson's disease in and on itself is not a concurrent or predisposing disease in terms of COVID infection. Which doesn't mean that, of course, we want to go out there and party and going into a crowd, but it's not comparable to hypertension or diabetes or asthma or other concurrent diseases that make COVID infection worse. The other good news that I've learned both from my practice and talking with many practitioners in the United States and internationally is that there does not seem to be a high number of patients with Parkinson infected with COVID. Actually seems to be a quite small number. There have been only very small series with 10 patients. I mean, 10 patients northern Italy where there are hundreds of thousands of infections. So Parkinson's disease patients seems to be somewhat being spared by this pandemic so far. And having Parkinson does not predispose you to have more severe COVID. There is no report of COVID, and having Parkinson's disease does not predispose you, does not make your immune system any worse than your peers, and your respiratory function is not terrible, and so should not predispose you. What happens, unfortunately, with the pandemic, with the crisis, with the stay-at-home orders, is that there is a less mobility, less access to physical therapy, less access to routine physical checks. And so the stress and the limitation caused by the crisis, not by the disease itself, but by the crisis, might have taken a toll in some patients. And so the silver lining has been the use of telemedicine, which is something that we have been trying to advocate for years, and we found a lot of limitations. And now COVID has opened up the use of telemedicine, which in this moment is open to everybody, even those who are across the street. But hopefully when this crisis will resolve, we will maintain it for the people that live 300 miles away, 500 miles away, and they don't have access to specialist care. And we will use the experience that we have accumulated during this crisis to take good care of them.
That's awesome. Okay, well, that was perfect. Very well said. Thank you so much for joining us, Michele. And I will just say that I think that, hopefully we've given you a sense from these speakers how much work goes into these clinical trials, from idea to birth, I guess, of the infant, of the medication that's ready to give to you as patients. And so it's important to be involved in the trials, advocate for funding, as Dr. Tagliati has said, and keep the dream alive for sure. And then even though we said that it doesn't predispose you or make the disease worse, we would both want all of our patients to be safe and sound. So continue to shelter in place if that's what you're being advised to do by your law officials, and stay safe, everyone. So we will look forward to more speakers next week, or at least one next Friday, I think. I'm going to pass this on to Rebecca, I think. I lost track of who's doing the moderating, but thank you.
Yes, thank you, Dr. Subramanian, and thank you so much, Dr. Tagliati. And actually thank all of you for joining us. Your questions today were awesome. that's what I love about the PD community, is that you guys just ask the best questions and are just so like thirsty for research and information. And so just thank you guys for being here. And again, thank you both to Dr. Subramanian for making this possible, and Dr. Tagliati for giving us your time. I know it's been a busy day for you. Real quick, we do have a couple of programs next week as well. We do have one on executive function on Wednesday, the cogwheeling of cognition with Dr. Farmer, and we do have a talk on addressing off time, so on Wednesday. And then we are constantly adding new programs, so please check out our website and see what we have coming up. Have a wonderful Memorial Day weekend, everyone, and we're going to end with our PMD Alliance wave to send us off, and I can't wait to see you guys next week. Thank you so much. Bye.
Bye-bye.
Thanks.